Hello, everyone, and welcome to another episode of the ASSFN podcast. I am Danica Paulo, current functional fellow at Baylor College of Medicine.
I'm Andreas Sayas, an MD PhD student at Duke University School of Medicine.
And I'm Hersh Shah, one of the seventh-year residents in neurosurgery at VCU in Richmond, Virginia.
And thanks for joining us for this episode. Our podcast episodes are a reflection of the Transition to Practice webinar series that's held by the ASSFN. And you can access both our podcast and the webinars on the ASSFN website, ASSFN.org, as well as Apple Podcasts and on the YouTube channel. And today for our episode, we're pleased to have two guests with us. First is Dr. Sharona Ben-Haim. She's an associate professor of neurosurgery at UC San Diego, and she's the director of surgical epilepsy, as well as a board member of the ASSFN. So thank you for joining us, Dr. Ben-Haim.
Alongside with Dr. Ben-Haim is Dr. Christopher Connor. He's the director of functional and epilepsy neurosurgery at University of Connecticut Health System. He did his MD PhD at UT Houston and MD Anderson in computational and theoretical neuroscience, and joined us by way of a functional neurosurgery fellowship at University of Toronto with Dr. Lozano. So welcome.
Thank you guys so much for having me here.
In considering your early transition into your practice, what is the best piece of advice you received on your first job transition process? And one thing that you may not have known at that time, but you wish you had known in retrospect?
Maybe start us off. So again, thanks for having me. Thank you for having this podcast. I think it's a really wonderful resource for especially people who are thinking about a career in functional neurosurgery or in the process of transitioning from being residents or fellows to having their first job in functional neurosurgery, or even those people who, are potentially already practicing neurosurgeons thinking about adding it into their practice. So as far as first job advice, probably the best piece of advice I got was, when deciding between, so number one, I feel really lucky that I even had options. I think that a lot of times, we look at our first jobs and, especially in exploring functional jobs and even specifically academic functional jobs, you really have to be at the right place at the right time a lot of times. But the truth is, it's very rare to get that perfect first job that's going to be exactly what you envision with exactly the right practice pattern. I think that's maybe not the way to think about it. And a piece of advice I got that I thought was really helpful was it's really not about the job necessarily that you are getting for that first year or first 2 years. It's really the growth pattern that you expect to see within that job, and whether you and the person who's hiring you, presumably your chairman or maybe the dean, are actually aligned in the vision and trajectory with which you want to go. And I found that really valuable when deciding between jobs. In fact, I had one kind of offer that was on the surface better than the one I ended up taking. I'm at UC San Diego now. But while that job seemed really great and lucrative up front, it didn't have the same potential for growth that I saw in the job I ultimately took at UCSD, where I really was aligned with the leadership here on growing and building an epilepsy program, and I really saw sort of how I would fit into the movement disorders program. Again, that's not to say I in no way got my first job and hit the ground running and had like a fully formed functional practice. That was very far from the case. It's really something that was built over time. I did there was a lot of general neurosurgery in the first couple of years of my practice, and I actually think that's a desirable thing. I don't think that's a bad thing at all, especially before you take your oral boards. That's something that you want to consider. You want to have those. You want to have those learning opportunities. The first couple of years of practice are times when you really solidify a lot of your surgical skills, and so I think it's definitely highly desirable valuable to continue and maintain a component of your practice as general neurosurgery as you sort of build a functional neurosurgery practice. So yeah, thinking about growth is definitely was a helpful way to look at it.
I think there's a really important component of that, which was what was going to be my answer. You have to have good support from your chairman in an academic setting, especially in the land of functional. We all have to be honest about ourselves and where functional contributes to the revenue cycle of your department. And there's a lot of things that are going to take a while to get going. The high points of functional are amazing, and they're the kinds of things that people want to put on press releases and that they want to get out and they want to talk about. But you're not going to get to that point unless your chairman's going to give you the kind of the space to do some of those things and is going to be really understanding of it. Before we started talking, I mentioned like, hey, I went over and I did pediatrics cases over at Connecticut Children's, and that had never been done. And, I had to tell my chairman, like, hey, I'm not going to be here for these days. I'm going to have to go do some clinic over there. We're going to have to physically take equipment over there. These are going to be things that we're going to have to deal with. And he was all for it because he was like, oh, this is awesome. This is great. This is what we should be doing. And he was super supportive of it. He didn't have to be. He didn't have to let me pack up a stealth machine and Lexel arcs and like take them over there where they could be lost or damaged, and there's all these issues with malpractice. His support made that possible. And that is what enables the growth. If your chairman hires you for functional, but really wants you to be doing more ACDFs and laterals or whatever, then that's what you're going to end up doing. And so you have to find that person who can have that vision and allows that to occur, because it's going to take a while for you to grow into your perfect boutique, functional practice. And that is, in my mind, someone had told me that, how important that was. I've seen people who didn't have that support and how much they had to struggle for the first 5, maybe even 10 years before they just got the heck out of Dodge. And that, for me, has been, I think, really critically important.
So I think that response actually leads us nicely into next question about, verbal support from the chairman and alignment of that with your vision for your practice growth is important. Beyond the verbal alignment in the chairman's support, what specific things as far as equipment, personnel, services, or programs already set up would you or did you look for when you were looking for different job opportunities?
Well, I'm going to be honest. I think that when you're talking about what you need and what they're going to give you, that's actually when you're much further down the process, as opposed to like, I'm looking at these 5 places that need a functional person. Which one am I going to pick? This is closer into when, you've interviewed at a place and you're starting to get to the point where they're forming an offer letter and they're going to start to ask you, like, what do you need? Like, this is the kind of thing you're going to talk about at like the last conversation you have with the chairman, where they're like, okay, this is going to happen or not. What do you need to make this happen? Some of these things you have to like really sit down and think, what exactly do I need to do to accomplish the procedures that I want to do? For me, the things that I'm passionate about realistically is I love epilepsy, but I'm really passionate about pain and I'm really passionate about deep brain stimulation. So it's like, okay, what the heck do we need in order to make that happen? And I was going to a place that hadn't done DBS in like over a decade. And so you're buying frames. So you're talking to Electa probably. You're making sure you've got a navigation system that you like. They didn't have a stealth. So had to talk to them about that. You've got to talk to them about, do you need a robot if you're going to do SEEG, that kind of thing. Some things that I think that are pretty critically important are, if you are going to be doing stereotaxy, something I hadn't even thought of that Sunil Kalia, one of my mentors in fellowship, told me, is like, look, you need to buy 2 frames. I'm like, no, we don't. He's like, no. What happens when you, pointing at me, drop something on the floor? Not that I've ever done that. Not that I have butterfingers. But, we've all dropped something on the floor. Some of us might do it more often than others. And when that happens, if you don't have a second frame ready to go, you're waiting for it to get flashed. Or if there's a problem with the frame, you don't have to cancel a case because there's a problem. There's some things that you're not going to be able to get around. They're not going to buy you everything. I've done almost all my cases with O-arm or with C-arm. I really wanted intraoperative CT. And they're like, we've got Arrow. We've got Stryker Arrow. And I couldn't go back to them and be like, okay, you just bought $500,000 worth of frames. you're buying me stealth and all that stuff. Also, you have to give me an O2. They would have just laughed at me. So you just have to, some of these things you're going to have to find a way to make it work. And you have to be open to those kinds of new things, knowing that someone out there has probably done it before. The company can probably put you in touch with that person. And if they really like you, they might even find a way for you to go somewhere and watch them get it done. So the Aero team was like, hey, we can send you to Chicago. They do it there. The guy there will talk to you on the phone. He'll even let you watch a case and make sure it happens. So I was like, okay, look, I'll just believe it. We did some test runs. Always, always, always practice with new equipment. I never used the Vantage frame before I did my first case as an attending. Never used the Aero. I didn't walk into the room with the first time with anything. We bought everything. Like I said, 2 of everything you can buy. So you have a backup. And we practice it multiple times with the team. And, you know, you're not bargaining power, know exactly what you need and what you can get away with, know what you can beg, borrow, and steal. And you have to know the bailout and what the fixes are going to be when all the new equipment breaks, because it's going to break. Everything that I bought has broken at least once, and we've never had to bail on a case. And we've had good outcomes 100% of the time. So those are the things I would tell you. But this is not a question that you're going to be asking, and the chairman's not going to ask you at the first conversation. This is at like they're getting a letter ready to go for you, and they're going to literally be like, what do you need? And that would be what I would tell you.
I could add to that on my end. I took a different perspective, you know, coming right out of residency and fellowship. I kind of took it as like, what's the minimal thing that you need to actually get this done? And I actually don't think that's the right approach. I was, for example, doing SEG with a CRW frame for several years before I was able to purchase a ROSA or convince the hospital to purchase a ROSA. And, you know, there's no question most of the bargaining power happens when upfront, because the question that they're asking, as Chris mentioned, is what do you need to make this successful? And if you tell them what you need, you know, they will try to get it for you, because it's not for you. It's for your program. It's for the success of your functional practice. And when you don't tell them what you need and you figure jerry-rig a solution, then you say you need it, they'll say, well, you're doing just fine. Like, look at you. You've done so great with your CRW frame. So that's something that I would say, you know, I would have done differently. I would have definitely spent more time and had a slightly different perspective in exact, you know, like figuring out exactly what I needed to be successful, rather than sort of saying I can make things work. And you really, it's hard to do that after you're already there and you're already doing the thing.
One thing I will tell you that I looked into, because when you ask for these things, by the way, this is the only part of the negotiation where you have an advantage. The other person on the side of the table negotiates a lot more than you, and they're a lot better at it than you are. But one thing that makes it asymmetric is that you know what a functional neurosurgeon needs, and they've like read about it in a journal. So, you know, as long as you're being honest with this person, don't lie to the nice person who's offered you a job and is about to pay you money for the first time and forever. But they don't necessarily know exactly what you need. You need to be honest with them, and you need to tell them what you need. So if you're going to do SEG, you need a ROSA. But I will tell you that one really great thing that my chairman did, because I asked for lots of things, and he was like, this is what we can get and this we can't get. There's sometimes what they can do in your contract is they can build in milestones into your contract. So I was like, I really want an alpha omega. And they were like, and I want a pony. And you don't get those things. And I was like, okay. But they were like, hey, if you hit 7 DBS cases in 3 years, we'll get you an alpha omega. First year we've hit 15 cases. They're going to buy me an alpha omega next year. That's what I get for Christmas in my stocking. So, you know, like build that into your contract, you know, and they put things in there about like a robot, you know, if I did a certain amount of epilepsy and SEG cases and stuff, which that's going to be harder for me to hit for a variety of reasons. But that would be something I would recommend to you in your contract that you can put in there, that they don't feel like they're giving that much stuff up. And that can be another way that you can get more stuff. That demonstrates to you that's like the growth trajectory that Sharona is talking about. That's the support that your chairman's talking about. That is something that no one told me that I really wish I'd known, was maybe it won't feel like they're giving you something if you make a milestone in your contract.
I love the example of the alpha omega. And my actual follow-up to that question is, are there ways that you can also both use research as a bargaining tool, but also bargain for research time? Like how does that fit into this picture of, entering into a new practice? And especially, I mean, in cases where both research is really well established, but also in cases where it's not so well established.
Yeah, I can really start that one off. This is a big question. How do you incorporate research into the model? You have to start out by understanding the finances that come along with this. It's unfortunate, but a career in research just doesn't compensate the same way that a neurosurgery career compensates. And so if you come to someone and say, I want to spend 50% of my time doing research and 50% of my time doing clinical neurosurgery, and you say to them also, I'm willing to accept that 50% of my time will be compensated on a researcher's salary and the other 50% will be compensated on a neurosurgeon salary, you won't have any pushback. That actually works out just fine. But if you tell them, I want to be compensated 100% at a neurosurgeon salary, but I want to spend 50% of my time doing research, then that's where it gets a little tricky as far as how the finances lie. It's really, what is your goal? What's your starting salary? What's your goal salary? Are there mechanisms of funding that are going to come in? You're not expected to come into a 50-50 academic, clinical research position with your own funding. That can happen, but that's pretty rare. And so most of the time, you need a runway of at least 2 years to really build a research program such that you can start even applying for funding that will help support that 50% of your research career. And so again, it comes down to the same issue we were talking about before with your chairman and your department and the vision of the school, of the medical school, or the bigger picture. Because having a research career and having an academic functional neurosurgeon that's doing really cool stuff with research, there's a lot of value to that doesn't exactly show up on the profit and loss sheet at the end of the year. There's a lot of bigger picture value to that. That could be extremely valuable from so many different angles. And you need to share that vision with the leadership of your department and the leadership of your school. And if they could share that vision with you, they see your potential and they're willing to support you on that level. Then that's when you can start to achieve, some balance with those two factors.
It's very tough to negotiate protected research time when you're just starting out with funding for all the reasons that Sharona's mentioned. I mean, it's also, again, she's saying some of the quiet part out loud, which is, there's financial components of this that are difficult to really work around, even though you're in academics and things. The reality of the situation is that you're going to need to find a way to get funding or something to demonstrate that value to the department, like writ large. I would also tell you that there's some stealth ways to try and make this happen that are a lot of people will think about while they're looking for jobs. Something I thought about. So I didn't get really any protected time at UConn, but something I did know was that coming from the world's busiest level 1 trauma center, Memorial Hermann, which Marsh can tell you is a crazy place, crazy place. And my trauma research has shown me that it's ridiculously busy. I went to a place that's not a level 1 trauma center, and that enables, a lot more time, even while you're on call, or things that you're not getting drained by that. And so there are stealth ways to look at the job and different things where you can think, I'm going to have about the same amount of call, but it's not level 1 call. I work at the Compression Fracture Center of Excellence of Central Connecticut, and that's okay. I can take those consults and that's fine, because I've only had to do a couple middle of the night cranies. Funnily enough, I had to do a suboc step at 3 a.m. the morning of my first stage 1 DBS cases and attending. That's the only one of those I've had to do. So, but most of the time I would say that there are stealth ways to like look at it and think about other things that are happening clinically that can still make it such that you can find that balance if you don't have protected time. Because as soon as you get funding, things are going to start changing. And that's what your chairman's going to want to be able to tell people in the administration. We have an R1 funded neurosurgeon, covers all manner of sins in terms of your RVU production.
But we bring up something that is one of our other questions, specifically when it comes to building a schedule and trying to make it so that you have some sort of balance between clinical work. How do you actually approach building that schedule so you have clinical work, you do take call, but you also have time for either admin or research or both?
And you forget also the rest of your life.
Yeah, and the rest of your life.
Component of that. That's a tough one. It's really a tough one to figure out. Unfortunately, it is a zero-sum game. There are only so many hours to the day, and you do have to give something up. If you are someone that wants to take a big administrative leadership role in your department or in your medical school, that's going to take time. Or if you're doing a lot of work with organized neurosurgery, that can take time. If you're doing research, that takes time. And of course, your clinical practice takes time. So, it's really important to have really hard stops about how those things interact with your family life or your personal life. There's no magic to it. You start off, you have a ton of time. Typically in your first 2 years of practice, you're still figuring stuff out. The practice is oftentimes not that busy. You have a lot of time. Use that time. I like to tell the junior faculty that come on, I remember I was kind of paralyzed by fear during that time, thinking I wasn't doing what I was supposed to be doing. And I don't think I used that time as effectively as I could have. That time will never come back. Once you get busy, you'll never not be busy. And so that's a great time to start your, research, to apply for, a K-12 award or some other, other grants. There's plenty of grants, or just to formulate your thoughts, to make connections, to build your practice. That's what you should be using that time for. Then you start to get really busy, and then eventually you hit some sort of ceiling of busyness where you can't take on new things. And then at that point is when you need to start really figuring out how to effectively delegate things to other people. So having an administrative assistant who can really, you can take things off your plate, take time off your plate by helping with scheduling or really all the little tasks that happen throughout the day. And then even in, other positions, administrative positions, leadership positions, really starting to figure out how to delegate projects to other people so that you can work together to accomplish goals, because you realize at some point you just can't do all of it.
There's going to be more resources around you than I think you necessarily know when you first get out. And we all have a tendency coming out of residency to want to do everything ourselves. And that's just not an efficient use of your time. I'm going to tell you something that's going to sound kind of not cool, but is real. When you're an attending, your time is more valuable than it used to be. And I spent like 40, 50 hours working on IRBs over the last couple of months, probably more than that, actually, trying to get a bunch of IRBs off the ground. And then someone's like, by the way, there's like a resource here at UConn where they'll help you out with your IRB. And I was like, no way. And they're like, yeah, like you have like some money, you can pay them. And I was like, holy cow, this is like absolutely incredible. And in like a week, they've done more than I could have done in like 2 months looking through all the forms and things. So that's kind of part of the delegation thing that I would recommend to you. And there's going to be people who are going to be more efficient at it and find ways to get people to help you a little bit. We don't want to ask for help generally when we're a resident. Start doing that a little bit more when you're an attending. Start asking people for help a little bit more. Just be nice about it. You're an attending, so people are going to want to say yes to you. And when they help you out, just be grateful for it. You'll be surprised how often people don't get thanked when they do something nice for an attending. So that is one thing. And then, as far as like research and science goes, kind of talking about this, kind of talking about balance, kind of talking about the last part, try and find collaborators that you like who can help you out, and check your ego at the door. If they just want to make you a co-I on a grant, or they want to do multi-PI grant or something, understand what your contribution to the science and the project is going to be. It's going to be access to human subjects, and just kind of ride the coattails a little bit while things kind of get started, and maybe think about what you want your lab to actually look like. And do I really want to have grad students in my lab? Do I want to have more of a postdoc lab? Do I want to have more of a distributed lab where I work with other people and we have funding and I'm just this random vague source like the wizard in the Wizard of Oz, who just feeds them data? Think about how you want things to look and find people to help you. And that's a real way to leverage other people's skills, levels other people's time for collective good and for collective advancement. I would say that. And then as far as this one last thing on the schedule, which is super practical, it's good to have kind of practical advice every once in a while. Try and get Monday OR days. And the reason for Monday OR days is if you do a craniotomy on a Monday, by Friday they're gone and you're knocking around on them on a Saturday or Sunday morning. And that leaves you time to go out to brunch with your wife. And then she doesn't leave you. So that would be one thing that I would recommend. And people like our OR coordinator called me in one day and she's like, hey, I'm going to move all of your days. I'm going to move all your Fridays to like this day. And you're only going to have Mondays and then these other scattered days. And she was like, are you okay with that? I'm like, yes, Karen, I'm okay with that. She's like, thank you. You're doing a favor for me. And I'm like, yes, I'm doing a favor for you. This is what I wanted all along. So that, from a practical standpoint, I would recommend that because you just round on them in the morning and then you go to clinic on a Tuesday. So that's my piece of scheduling advice that I didn't understand until came to attending. So if you can get Monday OR days, definitely.
Some people like Tuesdays, just to be candid.
Tuesdays are fine too.
Monday to be done with the weekend, and then Tuesday's kind of perfect. I personally actually have Monday OR days. I'm thinking about changing them to Tuesday, but after your talk, Chris, I don't know. Maybe I'll reconsider.
I bet your patients are gone by Thursday morning at the latest. They're probably rolling out Wednesday afternoon.
That is the beauty of a functional practice. I rarely have patients that stay more than 2 days.
Yeah. See, look at that. Tuesdays. Look, Mondays or Tuesdays. Okay. They're both perfect.
But after this podcast, Mondays and Tuesdays are going to be in such hot demand, it's going to be hard for us to get them. Yeah.
Yeah, but this is only going to be listened to by the functional guys. Okay. You think Mike Lawton is tuning into the ASSFN podcast?
Hey, might be.
Our goal is to make that happen.
Now that I've said this, of course, someone's going to like one of his BNI residents can be like, Mike, you got to listen to this thing. I'm going to say, Dr. Lawton, you've got to listen to it. Yeah, maybe he will.
Okay. So I think we'll have time for one more before we wrap things up here. When you're coming into a new practice or an existing practice as an additional provider and kind of expanding the program, what are some methods that you can use or that you guys have found successful or versus other methods you tried that maybe didn't work out so well to increase awareness about new services, to access referral networks that sort of already have some established patterns, and how do you sort of start to build that for your program and your surgical practice?
So one thing that you're going to find, especially while you're on the job hunt, is that an incredible resource are the device reps. And you can use them in multiple avenues here. One way that you can use them when you're on the road and you're interviewing for positions is they will know what a referral practice is like. The referral pattern is going to be like in a given area. So I was interviewing for a job that I really liked, and was pretty far down the path for it. And one of the reps in the area was just like, look, this is what the referral pattern is like. This person is really good. They're not going anywhere. They're young. And you're not going to be able to crack into this like you think you are. And I was like, I'm awesome. Of course that's going to happen. I did not end up taking that job. Someone else did. And I know kind of what's happened. And that resource is really handy in order to get that intel. The other thing that they will be helpful with is when you get out and they are trying to help you kind of get going, because you're going to have to work with them. You're going to have them come and get on service contracts and stuff at your hospital. They can also be like, look, there are these neurologists who are looking for people to refer stuff to. They're looking to find a place to send patients into. I'm happy to set up a meeting between you. And I know that doesn't necessarily feel great because it's like, it's like an industry thing or whatever. We all have to understand that functional neurosurgery is incredibly device and industry dependent, much more so than a lot of areas in neurosurgery, not necessarily spine, but a lot of other areas. It is very device dependent. We're putting devices into people's bodies a lot of the time, or we're using a piece of dedicated technology. Just let it happen. Be nice to them. They're not giving you a kickback or something. They're trying to find a solution for some patients. That's how I kind of look at it. But that is one thing that I've done, obviously. And so, like the pain reps, they're like, hey, these people need someone who will put in a battery on, a patient. You're like, okay, yeah, let's go out and let's have dinner and I'll meet them and I'll be happy to take care of their patients. That is one way that is one thing that happens. It just is. And sometimes, and if you're lucky enough to be at a place that puts in Medicaid or can take Medicaid patients, that can be incredibly valuable to large segments of patients. And the reps are really grateful for that because they might have a lot of patients who need to be treated. And so that's also something that I've used to kind of get referral patterns and stuff going is, just treat patient populations that other people aren't willing to treat for whatever reason. Just still helping patients. It feels good. And that can kind of help kind of jumpstart things.
Yeah. Just to add to that, I think really there's like endless amount of things you can do if you have the motivation and the time and want to do things, right? I mean, starting out with the concept that, in all of medicine in general, to kind of build your practice, you have to think of the 3 A's. That's, being available, affable, and able, actually, having good outcomes. That's something that just is true for any medical practice. And I think for us specifically, it's all about getting yourself out there. So actually having lunches, going to people's clinics, having actual symposia. You can do patient-facing events. You can do physician-facing events. Industry is super helpful because you are aligned in your goals to get knowledge out about a particular therapy and to get more referrals out there and to build the practice. And so they absolutely will help sponsor these things. Your program or department or university or health system probably also has a ton of resources. They usually have a whole department whose job it is to introduce you to referring physicians. And they have data, they have data on who's referring where, how they're referring, and they're there to make it not awkward. You shouldn't be setting up your own meetings. Other people are there setting up these meetings for you and really telling you who to meet. And so the kind of intensity and time you spend on this is really kind of clearly is going to be more when you start out your practice. And then it's really easy to just drop off. Once you get comfortable and you have your established set of referral patterns, it's very easy to just kind of not proceed because this is really it is really a time intensive thing. But it's important to sort of maintain that as a component of your practice, even once you're established.
Yeah, great points. Thank you so much, Dr. Connor and Dr. Ben-Haim. As somebody who's in this phase of transitioning from being a trainee to doing the job search and eventually soon becoming an attending, this is really a wealth of information. I've learned so much, and there's a lot to consider in this time, and it's quite pivotal. So thank you for your input, and I think everyone who's in the early transition period will also find your insights very valuable. So stay tuned for our next ASSFN podcast episode, and be sure to tune into the webinar on January 8th to learn more about transitioning to practice. Thank you, everyone.